Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host this evening. This is the first webinar of the season, so excited to have you guys here. We will be talking about caseless construction tonight. Excuse me. So I'll be trying to give you some pointers in terms of things to consider as you work on your list. On top of that, I'll show you some examples of prior case lists. For one thing, if you can start to spot the error, you can see what you shouldn't do on your list. And of course, I'll try to show you some examples of how to list things correctly. At the same time, if folks have any questions about particular cases that they're having trouble listing, a lot of times that's helpful because if you're having trouble listing it, chances are someone else listening in is also having issues. So having said all that, I'm going to unmute everyone as long as there's not too much background noise, and that way we can get started. So let's see, try to unmute you guys here. Can you guys hear me now? Hello? Leah, can you unmute yourself and tell me if you can hear me okay?
I can hear you now.
And you probably heard nothing before, right?
Correct.
Ah, rats. Well, I've been talking to myself for 5 minutes. It was a great conversation, I got to tell you guys. All right, well, let's try this again. Hi, everybody. Thanks, Leah. My name is Dan Green. I will be your host tonight. Excited that this is the first webinar of the season. We will be doing caseless construction pointers. So if you have any questions, please feel free to let me know. Raise your hand. I'm happy to unmute anybody and everybody all at once as long as there's not too much background noise. So was kind of start talking a little bit about the construction and the pointers behind the workshop. I've looked at several lists already this year. Some of them have been great. Some have been very tedious to review. The tedious ones generally have too much information and it almost reads like a novel. Remember, we want to make this as reader-friendly as possible. The first impression the examiner is going to have of you is based on what they see the night before. So remember, they're doing 6 hours of exams during the day. Then they have to look at 6 case list reviews, 6 sections to review at night. So if your list reads like a novel, it's very painful to get through. You want it to be complete enough where they have an idea of what you did, but at the same time, you also want to permit an opportunity to ask questions. So, you know, if you have a colposcopy and it says, you know, biopsy at 4 o'clock and 6 o'clock, CIN2 at 6 o'clock, you know, CIN3 at 4 o'clock, who cares? If she's got CIN2 to 3, or you could call it CIN3. They're not going to come behind you and do a colpo and go, oh, yep, here it was. Similarly, a breast exam, people put, you know, mass at 3 o'clock. Well, what difference does it make whether it's 3 o'clock or 9 o'clock or 6 o'clock or 11 o'clock or whatever? It doesn't matter. If she's got a mass, she's got a mass. So we want to try to be consistent and not have extraneous information that we don't need. I'll show you guys some examples of some of this stuff, because if you can point out the error, you'll be able to, on some of these case lists that have been submitted in the past, you'll be able to prevent yourself from committing those errors. At the same time, if you have any tough cases that you want to talk about tonight in terms of how to list them, I'm happy to try to help you with that. And even though it might be unique to yours, the situation, the overall case may be unique to you, but the problem that you're having probably is not unique and probably will still benefit other candidates. So one other thing I'll just mention, you know, sometimes people will put on their list, the patient will be diabetic, and so they'll put, you know, instead of putting diabetic management, they'll put ophthalmology consult, EKG, baseline labs, you know, fasting blood sugar, 2-hour postprandial, fetal echocardiogram, NSTs starting at 32 weeks, I'm making this up now, and the whole shooting match. Now, if you list everything like that on your list, what's the point of the examiner saying, well, what did you do for this diabetic patient? Because you've listed everything and you can read it as well as they can. So you're much better off trying to be a little bit higher level. So I always tell people, put in a situation like that, again, we're talking about a pre-gestational diabetic, I say put diabetic management. Now, you know, they could say, well, diabetic management, what does that encompass? Well, now I can go through all the things I just said verbally. But if I don't list that, they may talk to me about human placental lactogen or something like that, and what happens to the levels in pregnancy. So they may skip the easy questions and go straight to the more difficult questions. So again, these would be my suggestion. You want to think high level, you want to be concise, but complete. They should have an idea of what you did and why you did what you did when they're looking at your list the night before. Now, I am going to call on somebody. Victoria, can you unmute yourself? There you go.
I'm here. Yeah.
Hi, do you prefer Victoria or Vicky?
Victoria.
Okay, sorry about that. Well, Victoria it is. Can you see the screen? Can you see there's a couple cases up here?
Yes.
Okay, take a minute, look at these cases, and tell me if anything jumps out at you as being problematic.
No, there's no path on any of the cases.
Okay. Now these say tubal ligation, so
oh, okay, yeah.
that may or may not be a problem. Go ahead.
Under the second one, they put pre-op multiple. I assume they're meaning there's multiple other issues with the patient.
Okay, good point. What else?
I don't think you need to put in the asthma, borderline personality, or schizoaffective disorder, or even the seizure disorder in their previous pregnancy. Just that they desired
Okay,
permanent sterilization.
okay. Anything else?
Hmm, nothing that I can see.
Okay, good job. Good comments. All right, so let's go through them one by one. So first patient desires permanent sterilization. Okay, fair enough. Seizure disorder complicating previous pregnancy. I can understand. I can understand them including that because that is something that would complicate future pregnancies. So it certainly makes sense. When we start getting into the schizoaffective disorder and the borderline personality, that starts to make me wonder, does this patient rational and sound enough to make this decision? So I agree with Victoria. I don't think I would necessarily add that in. And the asthma, so, is it really necessary? If she had an asthma attack, in a hospital, either before or after surgery, by all means, I would encourage you to list it. But unless there was something super unique about what happened, that's really a borderline call to list the asthma. Now, look at what they wrote in the treatment. Counseling regarding post-sterilization regret, and then they did a laparoscopic tubal. So I would argue to you guys, if you're going to put counseling regarding regret, okay, that's fine, but you need to then put it for all of your patients. Because why are they singling out this patient, let's say, as compared to patient number 3? Well, patient number 3 is same age, but her parity, she's got one more child. So what they're saying is, patient number 3, no problem. You want your tubes tied, we're good to go. But patient number 1, she might have regret. So I'm going to counsel her differently. The bottom line is, whenever you do tubal ligation or salpingectomy on a patient, your counseling should be the same, whether they're 21 or whether they're 48. I agree that 21-year-old is more likely to have regret and certainly has additional risk factors for regret. But if you're not certain that the patient really wants a tubal ligation, if there's a shadow of a doubt, then you shouldn't be doing the tubal ligation. I just reviewed a list today where someone on their 2 younger patients had used Filshie clips, and the 2 older patients, they did salpingectomies. So it didn't say patient was unsure or anything, but reading between the lines, that's what it looked like to me if I'm reviewing the list. Because why the different procedures for the different patients? Now, again, there could be a perfectly reasonable explanation. If it were postpartum tubal, maybe, the insurance only covers a tubal interruption as opposed to salpingectomy. And I'm not saying the person should put that on the list, but they would need to be prepared to explain that. Getting back to this case.
Oh, sorry. I was just going to ask,
Sorry.
do you recommend under treatment for all the tubals to put that counseling part?
I don't, because I look at that as informed consent. So I don't recommend putting it. But if you are going to put it, the point is you want to be consistent and put it for everybody. Even your 45-year-olds that have 10 kids. They may regret not having done it earlier. That's a joke. Okay, so looking back, and Victoria's point, multiple, what does that mean? I think what they meant here was multiple, they've had multiple pregnancies or they have multiple children, a multigravida patient, for example, a multiparous patient. So more multiparous. But again, it's a little unclear the way it's listed. Desires permanent sterilization, that part's fine. Now look, in the treatment, it says counseled vasectomy. So I would argue, what is she even doing on the GYN list? If all you did was counsel her regarding have your husband or partner get a vasectomy, that's no surgery involved in that. She doesn't need to be. She could be on your office list, but certainly wouldn't belong on the GYN list. So this brings me to another point. Again, in looking at people's case lists, sometimes they'll put this whole long treatment, especially on the OB section. They'll put, hypertension management. They'll put, Pitocin augmentation, Foley catheter, and all this other stuff, that they'll list, but they will not list the type of delivery the patient had. So please check your list, guys, and make sure that it says, SVD if it's a vaginal delivery, or it says, CD if it's a C-section. And by the way, if you have any shoulder dystocias, please don't put SVD. Put vaginal delivery, because if you have a shoulder dystocia, by definition, it's not a spontaneous delivery. It's a vaginal delivery. And before the vaginal delivery, obviously, some people put, McRobertson suprapubic. Again, I would counsel you not to do that. I would suggest putting something in that situation like shoulder dystocia maneuvers. If you put McRobertson suprapubic, again, there's no point in them asking you, well, what do you do when you have a shoulder dystocia? Again, I understand it's not necessarily all the maneuvers, and they could be looking for, for you to go down the path for the additional things you would do. But again, shoulder dystocia maneuvers is much more generic, and you can discuss, hey, well, in this case, it was suprapubic pressure and McRoberts that relieved the dystocia. However, had that not worked, I would have moved next to delivery of the posterior arm. And if that didn't work, and so on and so forth. So again, the whole idea is you want to use this list to try to get the examiners to ask you certain questions or promote discussion. But you want to promote discussion about things that you can prepare for. So again, shoulder dystocia maneuvers. All right, well, I need to know all those maneuvers. I can prepare for that. Again, if you list all the shoulder dystocia maneuvers, they're not going to ask you because it's in black and white right in front of them. They can read like you can read. Okay, so getting back to this example up here, that's the problem with number 2. There's no procedure listed. Number 3 is probably okay. Previous ectopic with salpingectomy. Again, especially if you were doing a salpingectomy, you'd only have a unilateral salpingectomy. So it would be reasonable that they would list this in the history. So I'm going to try to unmute everybody again. Attendees will have audio control. Okay, so I've tried to unmute you guys. You feel free, if anybody has any comments or questions about this or anything we've talked about so far, to unmute yourself and chime in. You should have control yourself. If not, raise your hand. I will be happy to unmute you. Questions or comments, guys? Anybody have a case that they want to talk about in terms of how to enter it or suggestion? Again, just raise your hand. I'll individually unmute you. Okay. Don't see anybody at this point, so we will continue on. Let's see. You should be seeing another page come up. Leah, can you unmute yourself, please?
Yep.
Thank you. Can you see my screen?
Yep.
Take a look, and anything jump out at you here is kind of weird or that you would do differently if you were listing the case?
They list gestational diabetes, but then they don't say anything about diabetic management. They could have added that.
Okay.
I probably would have added something, some sort of detail about what they did for induction to say that it was failure, or to support that they had failure to progress just before listing the C-section.
Okay.
That's all that really
Anything
jumps
else?
out at me.
Okay. Very good. So let's go over this one. Again, if anyone has any comments, please feel free to raise your hand. So first of all, the first thing that jumps out at me is, how did they let it, even I know she's gestational diabetic, but how'd they let her get to 42 weeks? There's more of a trend and a movement to induce people certainly by 41 weeks. I'm not saying it's absolute, but definitely you'd think about a diabetic, you wouldn't want to get to 42 weeks. Yes. Could she go to 40 weeks if she's gestational and well controlled? For sure. Could she even go beyond 40 weeks, maybe to 41 weeks? Yeah, but you're starting to get into questionable practice at that point, because what do you have to gain? Now, if she's refusing induction, so be it. But then I would point that out. So that's one thing that jumps out at me. I agree with what Leah said. You know, I would want to put, first of all, I'd put gestational diabetes, and I would comment whether she's an A1 or an A2, so medication requiring or not. If she's an A1, I would definitely put diabetic management in the procedure treatment. Now, what would that include? So diabetic management could include things like checking, blood sugars, fasting blood sugars, and 2-hour postprandial. It would also include dietary counseling, exercise. So it would include those things at a minimum. If you're doing any antenatal surveillance, you could argue that it would include that, or you could list that separately. If she's an A2 and on medication, then I would put diabetic management, and underneath it, I would either put oral hypoglycemic or I would put insulin. And I think that would, take care of the gestational diabetes. Again, if you're doing antenatal surveillance, you can list it, or you can argue, as I mentioned, that it could be considered part of gestational diabetes. Failed induction. So they've listed failure to progress. So Jonathan, I'm going to see if I can get you off mute. Can you unmute yourself, Jonathan? How about you, Eden? Can you take yourself off mute?
Yes, can you hear me?
Yeah, thank you. So when somebody says failure to progress, what is that? How do you interpret that? What does that mean to you?
It's not very specific. I feel like a lot of people use it for failed induction of labor, but I've also seen it in notes be used like they were arrest of dilation also.
Good, very good. That's exactly right. So failure to progress, first of all, would not be a legitimate diagnosis to put here. There is no such thing as failure to progress, but you're absolutely right. In the lingo, we all use it, and we probably use it inappropriately. Failure to progress usually is associated with arrest of active labor, and it's often a substitute for that. But again, since it's not precise, and just as you said, Eden, it could be used for failed induction, it shouldn't be listed on your list anywhere. So now let's assume it were arrest of active phase. Is that the same thing as a failed induction? Eden, I'm going to unmute you again, or try to.
No, failed induction is different than arrest of active labor.
Exactly. So, and I've seen people's lists that say failed induction and arrest of active labor because they induced the patient, they didn't get them to deliver vaginally, so they called it a failed induction, and they also put arrest of labor. Now, I would argue that that says to the examiner, this person doesn't know basic terminology in OBGYN. I don't want to say it's scary that they're a bad doc or whatever. It may have just been a hiccup or something, but it certainly doesn't present a good first impression to the examiner when they see something like that, because you're absolutely right. Failed induction means we didn't get her to 6 centimeters, presumably with adequate Pitocin, hopefully with ruptured membranes as well for adequate time. Arrest of active phase means we did get her into the active phase, but she didn't dilate despite 4 hours of adequate contraction or 6 with inadequate contractions. So again, right there it says, hey, I'm not sure I know what I'm talking about, certainly as far as these definitions go. So you want to be really careful, and you want to be, check things to make sure that you're precise in terms of how you're listing these things. So those would be the things that jump out for me. I would also suggest, and this is a key point here, guys, it's just a nomenclature point. And when you're looking at your list, or you're looking at the program as, to where you're going to enter certain things on your OB list, anything that happens up until the time you write admit to labor and delivery goes in the antepartum complications. So if the patient comes in with a crappy tracing, you want to put like, late decelerations, that's fine, but first of all, you need to categorize the tracing. So call it a category 2 or 3 or whatever it is. Then you can put dash or in parentheses late decelerations. If it's present on admission, it goes in the antepartum complication. Once you write admit to labor and delivery, anything that happens from there through the postpartum period should go in the delivery or postpartum column. So if she's admitted and you're giving, let's say you're augmenting her, and suddenly the tracing starts looking crummy, then I would put category 2 tracing. I would put it in the delivery postpartum column. Usually in that case, unless it's super emergent, you'll put intrauterine resuscitation in the procedure treatment. If it were unsuccessful and you ended up sectioning her, then I'd put unsuccessful intrauterine resuscitation. If you deliver vaginally, then I would just put intrauterine resuscitation. Again, I know I'm speaking a little bit all over the place, but you want to have things in the proper columns, and you want to have something, generally speaking, it's not 100%, but generally speaking, when you have something in the complication column, you want to have something in the procedure treatment column that you did to address it. Jonathan, I see you have a question. There, you're off mute finally. Nope, you're back on mute. I have you logged in twice. I see it says you're having computer issues. Sorry about that.
Yeah, I'm just having some issues. I think I'm getting it worked out slowly.
You are. I just heard you for a minute. I'm not sure what happened.
Yeah, I'm on my phone, which is working.
Okay. Did you have a question or comment about anything?
No, just troubleshooting.
Okay. Sorry about that. Thank you. But feel free to chime in, please. Does anybody have any questions about anything that we've talked about to this point? Again, feel free to raise your hand. I think I may have said this at the beginning, but I don't know if it was maybe when I thought I was talking, but I was muted. Consistency, and we alluded to this with the last slide that we put up, consistency is absolutely critical for your list. So you want to try to list things the same way for, if you did them the same way for patients. I'll give you an example. If you have a patient on your list that, let's say, had abnormal uterine bleeding, that let's say she failed medical management, and so you ended up doing a hysterectomy. It's really important that you list the endometrial biopsy that you did. So you don't have to be elaborate about it. In-office endometrial biopsy showing dysynchronous proliferative endometrium. That's a bunch of waste of time. What you want to say is EMB, all caps, -benign. Now, so you don't need to list secretory or proliferative endometrium. The only time I would say that there's an exception to that rule is if the patient is postmenopausal, because if she's got proliferative endometrium and she's postmenopausal, obviously that's not normal. But you want to list the biopsy. Now, let's say you listed for patient number 12, and patient number 13 also had abnormal uterine bleeding, and you ended up doing a hysterectomy on her, but you don't list the endometrial biopsy. If I'm the examiner and I'm reading your list the night before, I'm going to say, hey, when the candidate does an endometrial biopsy, they list it, because look, for patient number 12 they did, but for patient number 13, there's no biopsy listed, ergo they must not have done it. So I'm going to assume that you didn't do the biopsy then. And if, then you're kind of behind the 8 ball. If they say, well, how come you didn't do an endometrial biopsy on this patient? Oh, I do it on all my patients. Oh, really? Because I don't see that you've listed it here. And I did notice on other cases when you did them, you listed it. Not saying that they're going to definitely doubt you, but it brings a shade of gray to, is this candidate just trying to cover his or her tracks, or did they really do the biopsy? So listing biopsies for before hysterectomies for bleeding, very important. Listing biopsies before endometrial ablations, critical. IUPCs before having an arrest of labor diagnosis, not arrest of descent, but arrest of labor, is also, I would argue, very important. And again, you want to try to be consistent with how you list things. Questions or comments? Okay, let me give you another little tidbit. So things to list. Now, I would never suggest that you guys should be dishonest when you're putting your list together, but at the same time, I would suggest there are gray areas. So if you have a patient that, let's say, is 30 years old that has a 4-centimeter ovarian cyst, I wouldn't necessarily list tumor markers on my list. I would personally leave it out. If they said to me, hey, did you do tumor markers? And I did them, by all means, I would say, yes, I did. And they might ask which ones. But I wouldn't list it because, quite honestly, it's a little borderline to do tumor markers on a 34-year-old with a 4-centimeter cyst, at least initially. If it gets bigger, it persists, maybe, but not necessarily with something like that. So that would be an example of something I would leave out. You might say, well, that's not being truthful. Well, I didn't put that I took the patient's blood pressure either. I didn't put that I did a CBC and pregnancy test on the patient before I took her to the operating room to make sure she wasn't anemic and that she wasn't pregnant. So there's a lot of things we don't list on the list. So again, that would be something that personally I wouldn't list. But again, that's, in the end, it's up to what you guys think is either good or bad for your list. One other suggestion, I know I'm speaking in like all over the place tonight, so I apologize, but I'm hoping that some of these tidbits will ring true for you guys. When you're putting your list together, I always suggest that candidates take a copy, like if you do a page, print out that page, and in the margin next to each case, put the pertinent positives and important negatives for that patient. Now, obviously, you won't be able to take in that handwritten document when you go to take your test, but you can practice from it, and it saves you having to go back to, dig up the whole history and physical or the pathology or what have you. So what I'm getting at, for example, is let's say you had a patient that had, let's say she's a 40-year-old G4P4. Again, let's say she had abnormal uterine bleeding, refractory to medical management, desired definitive treatment, and let's say ultimately you did a hysterectomy, but you did a TLH. So, if I'm the examiner, one thing I'm going to be, and let's say the uterus weighed 120 grams with some adenomyosis. If I'm the examiner, I'm going to be scratching my head going, what the heck? Why did this candidate do this 120-gram uterus on a para 4 laparoscopically instead of doing it vaginally? Now, you may not have put on your list that those 4 deliveries were all C-sections. Maybe that's the case, and I'm not saying you have to list it as 4 prior C-sections, but if you put in the margin in practice, from that handwritten list, when I say handwritten, I mean with the added information, that if that case comes up, they might say to you, well, how come you did this as a TLH? Oh, well, that's a great question. This particular patient, yes, she was a para 4, but unfortunately, all 4 of her deliveries were C-sections, and I was concerned about, scarring, particularly on the bladder or just in general within the abdomen. Well, now all of a sudden makes good sense. So that I would argue is a pertinent positive. Again, it's not critical that you list it. You can list it, but it's not critical that you list it, but it is critical that you remember it, so you're not going, oh, geez, yeah, I guess maybe, and then, like 5 minutes later it comes to you, oh, she had prior C-sections. Especially if you have a lot of cases, sometimes it can be a little bit hard to remember. But you have to know your patients and you have to know your list well when you go to take your exam. It's very, very important. If you don't know your list, the examiners get a little persnickety because they figure that you can't control what questions they're going to ask you, but what you can control is you can control knowing your list. So they're really adamant about that. Let me pause for a second. Does anybody have any questions or comments? Please raise your hand. I'm either putting you guys to sleep or people are too afraid to ask questions. Nothing? Okay, let's go on to another example down here. Okay, so let's see. Jonathan, can we take you off mute? Jonathan, are you able to speak to us?
Yeah.
There you go.
Go ahead.
Can you see the my screen?
Yes.
And so if you're the examiner and you're looking at this the night before, what questions do you have, or do you think it's entered well? Do you think it's a problem? What's your impression?
I feel as though menorrhagia is not the correct term anymore. I think we use abnormal uterine bleeding.
Okay.
The focal high-grade squamous intraepithelial lesion, I feel like that should have been assessed prior, via kind of having a known pap smear. Personally, that may be incorrect, but and then you need the pathology from the actual uterus. I want to say that focal high grade is talking about the cervix, maybe.
Okay.
And it's also a rather
Anything else?
small uterus for a TAH.
I would agree with everything you've said at this point. Anything else that bothers you?
That's all I can see immediately. Oh, I guess uterus benign. I guess that counts as pathology, maybe. Maybe.
Yeah, I would think that could. I would list it differently. I would say uterus 160 grams. Then I would put cervix endometrium dash benign. So I would list it more by structures within the uterus. But I agree. It could be a little sloppy. Any other comments?
That's the only thing I see kind of immediate. Maybe. Yeah, that's the only thing I can see like an immediate kind of flag.
Okay, great. All good points. I would agree with you. So let's go through it. So pelvic pain. Okay. It doesn't say that we tried medical management, that she declined medical management. Nothing. We didn't. For all intents and purposes, we didn't do anything other than say, "Oh, you're having some pain. You're having heavy bleeding. Guess what? I've got a spot on the OR schedule for Thursday. I'll see you then." So it doesn't look like we did anything in terms of trying to treat this patient other than taking her to surgery. So, one thing, again, refractory to medical management is a good buzz term or phrase. Decline medical management, desired definitive treatment, these are all things that you can use, and you don't have to use all of them, but you want to kind of convey to the examiner, hey, this is what I was dealing with. It wasn't like I just said, okay, we'll go straight to the OR. We talked about endometrial biopsies. So here I would hope that they did a biopsy, and you might say, well, she's only 38. Well, yeah, but if her bleeding's bad enough that I've got to take her to the operating room to do a hysterectomy, I don't want any surprises to find out, hey, oh, she had hyperplasia. And maybe I did the wrong surgery because maybe she actually had cancer if she had endometrial intraepithelial neoplasia. So to Jonathan's point, the focal high-grade squamous intraepithelial lesion, first of all, that's a cytologic diagnosis, technically. But more than that, if you've got a patient that's got cervical pathology on your specimen, this is going to be a case where I would argue that you need to list the pap smear. Because, if the pap was normal and this is what you ended up with, okay, why would you have screened the patient differently? But if the pap was abnormal and you let it go, I mean, holy cow, she could have had cervical cancer. Again, we would have done the wrong surgery, which maybe should have done a radical hysterectomy, not obviously for CIN3 or a high-grade lesion, but if it were something more serious, we should have worked it up with Colpo beforehand. So, you'd want to list the pap smear as normal, or if it were abnormal, pap, whatever, Colpo, CIN3, status post-LEAP, whatever it was that the patient had as it addresses the cervix. The other thing, so the TAH, why did we do a TAH on this patient? Nowadays, of course, missing the salpingectomy, this is an older case list entry, but certainly the salpingectomy would be relevant. And then the cystoscopy. Our cystoscopy is routine for hysterectomies. Again, a lot of you do, certainly in your laparoscopic cases, are doing cystoscopy. I'm not saying it's right, and I'm not saying it's wrong, but you need to be able to prepare to defend it because it's not absolutely recommended and it's not contraindicated. The truer recommendations would be to do it when you're suspicious or that the patient is high risk for having an injury. So if you have a lot of adhesiolysis type dissection. But again, a lot of people do it routinely in all their laparoscopic cases. You just have to be prepared to defend it. Any comments or questions about this one? Okay.
I have a quick question.
Yep. Go ahead.
If we routinely do cystoscopy with a TLH, should we be putting that
Should you be
under
putting the
procedure?
cystoscopy? Yeah,
Yeah.
you really need to. Yes.
Okay.
You don't want to not put a procedure on that you did. I mean, because if they
That's
ever
fair.
audit you, which is extremely unlikely, they'll think you're trying to hide something.
Okay. Thank you.
Sure. You just want to be prepared to discuss it. Okay. So let's see. Victoria, I think you're back. You're back in the hot seat. Can you unmute yourself, please?
Yeah.
There you go.
Okay.
So now, if you were reading this list after 6 hours of work and you had 5 others to do on top of this for this one case, what would you be thinking?
It's a lot of information and you can't really tell what they're trying to say, I think.
Exactly. I mean, this is like a nightmare to read.
Yeah.
I mean, if you look at the first one, patient 22, abdominal pain, fever, and chills, postmenopausal status, suspected early appendicitis, and admitted by general surgery. They had no response to IV antibiotics. Complex cystic pelvic adnexal masses up to 9 centimeters with internal debris on ultrasound. They're going through their whole process in terms of what they're thinking, and they're written like in complete sentences. This is so unnecessary. And if I'm reading this the night before, I'm thinking this guy is worried about, even coming up with his differential as opposed to just, listing abdominal pain and fever with, concern for tubovarian abscesses or with bilateral adnexal masses. And then they can say, well, what was your differential? That would be something I would much rather fill in verbally if this case comes up than having all this verbiage. And if you look even over at the benign cyst, 8 by 7.5 by 6 centimeters, and then they put the weight on top of it. I mean, it's too much information. If I told you it was an 8 centimeter cyst versus an 8 by 7.5 by 6 centimeter cyst, do you get the? Have I told you anything any different?
No. Because if it's 8 centimeters, likely the other dimensions are going to be pretty large as well.
Exactly. And so I really haven't added anything. I've just made it, that much, added that much more in terms of typed print that the person has to get through. So, kind of be careful when you're looking at when you're putting this stuff in. Again, is it really necessary for the case? Or is it just, added fluff? And I would especially tell you guys that with the pathology, please don't copy and paste what the pathologist wrote in the report. If somebody's got chronic cervicitis, but their PAP ahead of time was normal or whatever, it's benign. Now, look, if you have postcoital bleeding and you're, in the office and you do a biopsy and it's chronic cervicitis, fine. But if if it's part of a hysterectomy, and again, it was not for some problem from the cervix specifically, don't list chronic cervicitis with squamous metaplasia. Who cares? It's benign. That's really all we care about. So again, same thing with endometrium with progesterone effect. I mean, okay. If it's benign, it's benign. Don't waste your time and don't waste the examiner's time. All right. Thank you. Victoria, did you have any other comments or questions?
No, I think that's probably how I first started my list, and then I just obviously cut down everything.
Well, if you're sending it in for review, I will promise you that your reviewer will love you for cutting it down. The one I went through yesterday and today, I just was painful.
Yeah. Okay. Thank you so much.
Thank you. So Leah, can you unmute, please?
Okay.
There you go. Thank you. So take a look at what we've got up there now. What do you think of this? Remember, you're the examiner the night before. Forget the patient initials and hospital number. Good, bad?
Pretty straightforward so far. On the second one, the pathology seems a little confusing, like the acute and chronic inflammatory cells. I'm not sure what they're referring to.
I would agree. Excuse me. I would agree with you. But I will tell you, I think this list almost is not, it's not perfect, but I think it's great. If you look at it when you're sitting down, if you were the examiner, tonight reviewing it for tomorrow's test, first of all, it's not killing you to get through these cases. It's presented in a way that's relatively easy to read. It's not like a bunch of words that just run on. So to that end, I would encourage you guys, one thing per line, one condition per line. If it stretches out to the next line, like the bottom one where it says desires permanent sterilization, you can see it's across two lines. But and that's fine. But what I would suggest then is if she had another diagnosis, skip a line and then list it. So the spacing between your entries, you can see, makes it much more readable. And if not spacing, at least listing one condition per line, not like, menorrhagia and then, comma, pelvic pain, comma, dysmenorrhea, whatever. That's very hard to read. So try to set each diagnosis or condition off on its own line. Now, the one issue I would take with this, and I agree with what Leah said about I'm not clear on what some of these pathologies mean, but the one thing I would say is the failed medical therapy. I know that technically it's treatment, but by convention, it's better listed in the diagnosis pre-op or admission because it's what you did before you took the patient to the operating room. You didn't try medical therapy in the operating room. We can be sure of that. So the only suggestion I would make here would be to put the failed medical therapy under the pre-op diagnosis. Comments or questions about this one, guys? All right, let me give you another just general pointer. When you put together your OB list, and I've seen it probably a little bit more this year than usual, but the Gravida and Parity, please make sure that that you don't count this delivery in the Parity. So you can have a G1P0, but you can't have a G1P1 who's pregnant. She'd be a G2P1 if she's already got a kid. And if she doesn't have a child, then she'd be a G1P0. So please make sure that you're not counting the pregnancy in unless she's more than 6 weeks postpartum. You could count it in that situation. There was something else I was going to tell you guys about that.
Can I ask a quick question about that? Yeah, so we have a lot of Amish patients near us. So a lot of them are dropped off at the ER after they deliver with postpartum hemorrhage. So their G's and P's would be like a G8, P8 who ends up on the door. That's okay because even though it's this current pregnancy, she has delivered.
Right, but delivered when?
Like earlier that day or the day before.
Yeah, I would not count that delivery in the Parity. Yes, in the Gravida, but not in the Parity.
Okay.
Again, would want her to be out of the postpartum period before I count her in the Parity. By the way, guys, and I've seen this on a couple lists recently, you can only list a patient one time anywhere on your list. So that's not like one time on GYN, one time on office, one time on OB. It's one time period. So I had somebody's list I was doing today. The patient had cervical dysplasia during pregnancy, and postpartum, she ended up with an excisional procedure. So I happened to, it caught my eye on the GYN section, and then when I went to review her OB section, I saw the same patient. So that would be kind of a no-no. What you'd want to do is you'd want to list her on your OB list and say, you know, postpartum, 3 months postpartum, I'm making this up, 6 weeks postpartum, whatever, patient underwent LEAP for CIN3, margins clear. And then you wouldn't list her on your GYN list. Now, by the way, if you have a patient that your colleague does the delivery, so midwife, family practice resident, partner, whatever, you don't list the baby information there. So no APGARs, no weight, all that kind of stuff. You would just list the mom's length of stay. And what I would do is, let's say the patient has a vaginal delivery, she's on the floor, and a day later she develops, has a postpartum hemorrhage, a delayed postpartum hemorrhage. So what I would put is in the delivery complication, I would put delayed postpartum hemorrhage. I'd put SP, status post, with a slash in between, status post SVD, and in parentheses I'd put by colleague, 1 day or 24 hours ago or whatever, or postpartum day 1, status post SVD by colleague. So that's how you can get away with that. Now, some people, I looked at a list yesterday where the candidate put the prenatal care was done by a colleague, and they put, diabetic I'm making this up now, diabetic management, and they put in parentheses by colleague. So the only time you need to distinguish if it's like prenatal care that was done by your colleague instead of you is if you would have done something differently. So if, unless they did the procedure, like in this case, the delivery, or if they did a cerclage or a version or something like that, then I would list by colleague or partner. But if it's something like, the prenatal care, but you would have done exactly the same thing, there's no point in putting by colleague, because if you had managed her, you would have done the same thing. Does that make sense to everybody? Questions about this? I think you're all able to take yourselves off mute if you want. So please feel free to chime in. Okay, so here's another list. Eden?
Yeah, I'm here.
You could ask a question? Okay, if not,
Yeah.
You're up. How does this
no,
list
I wasn't.
look
I was just
to you?
unmuting myself.
If you're getting ready. I'm sorry, did you have a comment or question though?
No, not at all.
Okay.
This list looks like it's spaced out very well. It's not as overwhelming as 2 pages ago.
Yeah, I agree with you. I think this
Looks pretty good, actually.
Generally looks good. Let's see. Now I would say the
Maybe
endo,
Mineralio.
if you look at the bottom one where it says endo, they wrote 9 centimeters. I'm hoping the endometrium's not 9 centimeters wide. So you want to be careful with your units. And one other point, if I tell you nothing else about your office section, actually, let me give you 2 pointers about your office. Please, and you'll thank me for this if you were thinking of doing it and you don't do it as a result, please don't put your most interesting case in your office section. I have people that every year when they're doing mock rolls at the course, they're like, oh, and, I'll say you have such and such, something I've never even heard of. And they'll go, yeah. I'll go, oh, well, tell me about that. And they'll be like, oh, I haven't really studied this yet, and da-da-da-da. Like, why'd you put it on your list? Well, I thought it would be interesting to discuss. Yeah, but you got to spend a whole day to learn about it. So please don't do that. Like primary amenorrhea, unless you're a pediatric gynecologist, I would never put that on my list. That's like my nightmare. Or ambiguous genitalia, I would never put that on my list because I wouldn't want to discuss it. Doesn't mean they couldn't ask you about primary amenorrhea, but I certainly wouldn't serve it up to them on a platter. So that would be my recommendation. Don't find the most interesting case. Now, having said that, you know, don't just have like all patients with BV. So if you have like undervaginal disease, put, you know, a patient with bacterial vaginosis and another one with a yeast infection. If you're under well woman visit, don't put, you know, a 40-year-old and a 45-year-old because the screenings and testing and vaccinations and all that stuff are going to be the same. Having said that, some people like will put well woman visit, for example, they'll have a patient with a breast lump and they'll put well woman visit, then they'll put breast lump or breast mass, and then they'll put the workup for the breast mass, but leave out the stuff for the well woman visit. If you put well woman visit on your office section, be prepared. You've got to be able to talk about, and you still have to include all the age-appropriate screenings, the age-appropriate counseling, and what vaccinations would be relevant. Now, again, I suggest that people don't put, fasting lipids, glucose, urine dip, and mammogram, and list, everything singularly. I would suggest putting age-appropriate screening for a well woman. And for counseling, I wouldn't say talk to the patient about diet, exercise, calcium, vitamin D, safety issues such as seat belts, vaccinations, including, let's say she's old enough, pneumococcal and shingles. I mean, again, that's listing everything. There's no way that the examiner's going to ask you about it. Rather put age-appropriate screening. Well, what would be age-appropriate screening for a 60-year-old? Oh, well, for a 60-year-old, I would include, and then you go through the list. Age-appropriate counseling. I see you've written here. How did you counsel her? Well, at age 60, I'm going to recommend that she be on 1,200 milligrams of calcium a day, 600 international units of vitamin D. I'm going to recommend that she, make sure she's using seatbelts, make sure she's safe in the home, domestic violence. I'm also going to review her vaccinations as well as diet and exercise with her. Oh, really? What vaccinations? You see how that conversation goes? But if you list everything, obviously there's no point in them asking you. Okay, let me stop there. Anybody have any, Aiden, I didn't mean to take all your time and talk over you. Any comments or questions
okay.
about what I just said?
I do have a question. If you have a well woman exam, so you put that under at like the far left column, and you then put age appropriate screening, do you need to then list like lipids normal, glucose screen normal, urine dip normal?
No.
If it was obviously all normal.
Right. So you can do one of two things. You can either list and say, age appropriate screening, and then you can put dash normal, or you could put you could put it in the results. You could put labs normal, but don't list the individual labs because again, it defeats the purpose. Now, what you can do, let's say everything was normal except for her LDL was 170. You could put normal and then list the LDL as 170. So just list the abnormal.
Okay, thank you.
Sure. And as long as we're talking about well woman, holy cow, I had somebody on, let's see, Sunday. Friday, I was looking at her list, and for every well woman, instead of putting like history and physical, which you can put or not put, she put breast exam and pelvic exam. Oh my gosh. That's like, it's not a failure, but it's she's going to get, if she leaves it like that, she's going to get a super hard time on the exam. Why is that? Because it looks to the examiner like all you think of as the patient is, I'm doing a GYN visit. Remember, they're thinking of us as primary care providers. I'm not saying we're super gurus, intensive internists, but they're expecting you to be able to manage certain things. So if you have a patient under pre-op evaluation because she's got comorbidities, it's not good enough to put her under that category, say she's got hypertension, maybe heart disease, and just say referred to primary care for pre-op clearance. or if it's your office list, it's not good, and it's under, you know, management of medical conditions. And let's say the patient's hypertensive, it's not good enough to say referred to primary care for hypertension management. They're going to expect you to be able to do first line stuff. So if you have a patient on the office under medical conditions and you have hypertension, they're going to expect that you could start the patient on, you know, a beta blocker or a diuretic or maybe an ACE/ARB. Now, if the patient needs 2 or 3 meds, they're not going to expect you to do that. You know, if you have a brittle diabetic, they're not going to expect you to manage that. But again, it can't just be like patient came in with back pain, so I sent her to orthopedics and physical therapy. You know, they're going to expect you examined her, did a straight leg raise. You know, if the straight leg was positive and you were concerned about a disc problem or she had neurologic impairment, that you would, you know, get her the MRI and get her in to see somebody. So again, something a little bit more than just a straight out referral. So please bear that in mind when you're putting cases on your list. And again, especially if you're doing a well woman visit, they're going to expect you at a minimum, exam-wise, to check the thyroid, listen to the heart and lungs, do a breast exam, abdominal exam, pelvic exam. And, you know, when I say a cursory neuro check, they're not going to expect you to, you know, do a Babinski and all that kind of stuff. They're not going to expect you to look in the ears unless the patient has a complaint. But it's more than just a breast and pelvic exam. So please, whatever you do, don't just list breast and pelvic exam under your workup diagnostic tests. Questions about this? Giving you guys all my best information. I can't believe nobody has any comments. Well, we're coming up on 9:30, so let me pause here. Oh, let me show you one more thing before we pause. If you guys can see the screen, if you look at the bottom where it's circled, I know if you've taken or listened to, sometimes Alvin will talk about punctuation. Excuse me. Punctuation is okay on your list in moderation, and I mean that in capital moderation. You know, once or twice per section, but not. I mean, I have some people that put exclamation points about everything, and then it just becomes monotonous. So it has to be something that's really unusual, like you know, you're doing a laparoscopy for a 10-centimeter ovarian cyst, and you look in and there's no cyst. That might be something I would put an exclamation point for, but you know, just don't overdo it because it gets monotonous for the examiner, and they're like, I'm not going to ask them about that specifically because they put a exclamation point and they're trying to bring attention to it. All right. Having said that, let me stop here. Any questions about anything we talked about tonight, or just in general as you're preparing your list that I might be able to answer for you? Jonathan, if you can unmute yourself, please do. If not, I'll try to. There you go.
Just confirming one thing. So you mentioned colleague deliveries. I must have been incorrect. I did not put my colleague deliveries on there because I didn't personally do them. Is that incorrect?
No, you're right. You wouldn't list your colleagues' deliveries just to list them. What I guess I'm getting at is if there was something that happened in the course of that patient's care. So your colleague does the delivery, they call you, you know, you're on call, they go home, they call you, you know, 6 hours later because the patient's got a massive vulvar hematoma. So now you're addressing the hematoma. So you're now involved. But if, you know, if they had a vaginal delivery and you round on her the next morning and she's good to go, and or 2 days later, whatever your length of stay is, doesn't matter. But no complications, no, you would never list that.
Okay. All right. Just making sure.
It's only if you're, yeah, no, good question. It's only if you're involved in the care, you know, directly, more than just like rounding post-op or postpartum. Thank you. Anybody else have any questions or comments? Jonathan, if you have anything else, please feel free to chime in too. Well, if not, I will wrap it up for tonight. There'll be next week, they'll be going over some structured cases next week. I'll speak to you guys at the end of the month with a few more tidbits of information. Eden, did you have your question mark is up?
No, sorry, just saying it was super helpful. Thank you.
My pleasure, and thanks for dialing in. I'll tell you guys, sometimes the first one of the year I've had to do these where I talk to myself literally for 45 or 50 minutes because no one dialed in. That's really monotonous. So thank you guys for joining me tonight. Hope you all have a great 4th and good luck with your case list. I'll be speaking with you toward the end of the month. Have a great evening. Good night.
Thank you.
My pleasure. Good night.